Thank you. Firstly, I just want to say thank you for you all for staying till the end of the day to hear me speak. It's Friday afternoon. I actually thought I'd be speaking to no one, so the fact that I've got some of you here is quite impressive. The fact that I've got a lot of commissioners here makes me really, really petrified, because commissioners and clinical commissioners makes it even worse. So thank you. I also think that I've drawn the short straw because, to be honest, we've had a list of speakers today who have been absolutely brilliant. I've not been able to sit into as many as I hope, but the ones I have sat in, I've learned absolutely loads. I'm making contacts with loads of people. I want to go out and do loads of work shadowing. I really want to get to understand what different people are doing in their job, so that makes me more efficient and effective in my job. So that's brilliant. I hope you've all had a really good day and really, really enjoyed it, and I hope you've got a lot out of attending, and that I hope that my chat in the next 10-15 minutes is going to continue with that vibe and you're going to kind of enjoy it. So, I'm here to share with you what my role as a commissioner is of health services, what an average day looks like for me, what challenges me, what vexes me, and what I'm employed to do. So the first thing I want to say to you all is just how much I actually love my job. Don't get me wrong, I can go home at the end, don't tell anybody, don't get me wrong, I can go home at the end of the day feeling absolutely frustrated and as emotionally drained as the next person. But the number of people that I get to work with, the positive impact I hope I'm having on people, even if it's in a small way and not necessarily directly, but actually just knowing that I'm working in a system supporting my own community, filled with altruistic people who share my value set. It gives me the strength to get out of bed in the morning when, to be honest, I just want to pull the covers over my head and just, ignore the rest of the day. So, what does a commissioner do? Well, actually, I've been asked that quite a lot, especially by some of my frontline colleagues who are involved in delivering direct patient care. Why do we need commissioners? What do they actually do? Would it make a difference if we didn't employ them? They're all just fluffy, aren't they, really? They don't really deliver anything tangible. Shouldn't we be using the money to actually employ more nurses and doctors? Well, it's all really good, valuable questions, actually. And when we're working in such a cash-strapped system, it's actually really, really important to make sure that everybody who is employed is really delivering against what we need to do. So, what I need to be able to do is really kind of explain to you why I think it's really important that commissioners are working in this system. So this is a little bit out of date now, and the reason why I've got it on is I'm going to go through, but I think the best description of the role of a commissioner was written about 15 years ago, and it was when the Department of Health started talking about world-class commissioning. They identified 11 different competencies that a commissioner was expected to have, and I actually think it's still a really good framework for what's expected from us as commissioners. The actual competencies are a little bit dated. The language that they use doesn't really fit in this new world of integrated work. I know, I'm sorry. I agree. But yeah, on the whole, it still gives a really good feel. So I've got them all written down, so I'm just going to run through them quickly for you, and then you make your own judgment which ones still really fit or which ones are a little bit out of date. So competency 1 was around leadership. They're a bit noisy out there, aren't they? Can you? Yeah. So competency 1's around leadership, making sure that we're proactively leading on the agenda locally and being viewed as a leading authority. Competency 2 around working with community partners, considering the wider determinants of health and collaborating with local governments, other partners to develop shared ambitions. Competency 3, engaging with the public and patients, acting on their behalf to make decisions. Competency 4 around collaborating with clinicians, gaining the best clinical advice and insight to inform decision making. Competency 5 around managing knowledge and accessing local needs, assessing a range of intellectual sources including joint strategic needs assessments. Competency 6, prioritising investment, gaining a sound knowledge of local needs in order to decide on strategic investment plans. Competency 7, stimulating the market. Competency 8, promoting improvement and innovation, continually seeking improvements to services. Competency 9, securing procurement skills, building productive relationships with providers. Competency 10, managing the local health system, working with providers to improve and sustain services. And competency 11, making sound financial investments. So you can see why I wrote them all down, because obviously I haven't committed them all to many. And I'm hoping that quite a few of you who are in here as commissioners really see those set of competencies in terms of the way we work. So I believe what's changed over the last 15 years is the understanding of the complexity of the health system, the health and care system that we are working in, and the realisation that leadership and management of that local health system can't be undertaken by just one organisation or one set of people. We now appreciate, lots of us now appreciate, that to deliver what's needed to improve the health of the population takes much more than market management and good procurement skills. We work in a complex and adaptive system, and our drive to simplify and micromanage outputs doesn't necessarily correlate to the outcomes that we're wanting to achieve. So as commissioners, we really need to understand the communities and what their health needs are. To do this, our job is to look at lots of population data around incident and prevalence rates, national guidance around demand profiles, local service data around access and outcomes, and alongside all of this quantitative data, we gather qualitative intelligence. We speak to service users about their experience, we speak to service providers about their service offer, we speak to regional and national teams about their priorities. And what we're expected to achieve, we speak to other statutory partners such as local authorities, police and probation to understand what's important to them, and how they're shaping their services. And as commissioners, we do a lot of talking. And some of the really good commissioners do a lot of listening. We then work with all those people with lived experience, professional partners and stakeholders to start to co-produce what the services are needed for us locally to make sure that we're achieving the three aims of addressing the inequalities, reducing unwarranted variation in care, and improving the efficiency of investments in terms of both economic and social return. Working within the integrated care system means that Commissioner is not expected to develop a specification in a darkened room, and which then gets published to the market, stimulating competition, but potentially baking in the inefficiencies and the clinical variations. So what is the role of Commissioner? The role of the Commissioner is to facilitate and engage in conversations where the expertise and knowledge of all of the people with lived experience, professional partners, stakeholders, is all valued equally. And it focuses on the three pillars of quality, safety and cost. The Commissioner has to share their expertise on procurement legislation and sourcing approaches to ensure that we meet not only our legal duties, but we've also got a role in describing the strategic context in which we work, both in respect to local and national priorities, drivers, policy decision, legislation and guidance. We've also got a role in market management. We need to share the details of our priorities and work plans to make sure that we've got providers in our areas that can really deliver, have got the skills and workforce to deliver the services we need, and that those providers can make long-term investment decisions with confidence that can really help delivering what we need in the long term. Then the final part of the commissioning cycle is that Commissioner's role is monitoring whether the outcomes that were required are being realised, ensuring the investment is delivering with value for money and the quality of the services. That's all great textbook, really, of what Commissioner needs to do. But how does that compare to my daily life? Well, as many of you who actually work with me every day now, I spend most of my time in meetings, which is, massive, but I know it's not just common in the NHS, it's now common across society. Busyness is the new currency, and actually sitting on MS Teams is the new way that we work. When I'm not in meetings, I'm often providing assurance, either to internal committees, partnership groups, boards, or regional assurance around how we're meeting the mental health needs of the population and how much it's costing, what the risks are and how we plan to mitigate them. And that stuff's all really, really important because we have to be able to evidence what we're doing. But to be honest, that's not the bit of the job that I really enjoy. The bit that I really enjoy and the bit that makes me smile is that I actually get to facilitate groups of passionate people coming together to discuss how to improve and transform services within the financial constraints that we've got. I get to be part of a team of people who work out how to make the changes and really deliver the improvements. I get to spend time with services who are supporting people and providing care, and I get to speak to wonderfully compassionate people who often come into their job either because of personal experience and mental health or the absolute drive to be a positive factor in the lives of some of the most vulnerable people in our society. My role gets me the opportunity to suggest that we hold a festival in South Normanton at the end of September because it'll be a brilliant way to get people together and rebuild relationships, make new friends, thank people for all of their hard work for the last couple of years and get input into what's really important for this Alliance partnership and to work and gain a better understanding of the things that's out there to support our population. But my role also requires me to use a brand new set of language. So in commissioning management speak, I can describe the expected outcomes of today and what we've actually managed to achieve as, get this, I'm going to read it out here. So the outcomes of today was reducing inefficiencies through streamlining services, access and support, reducing variation in care through greater understanding of local provision and access criteria, and most importantly, supporting provision of integrated care through the breaking down of organisational egos. And not an acronym in sight. Thank you to everyone for staying to the end of the day. Thank you for coming along and being part of this journey. And seriously, thank you, everybody, for everything that you do for the people of Derby and Derbyshire. Thank you very much.